I think payers, whoever's in charge of the purse, needs to be looking at these newer medications. They're not just newer medications that we're talking about because they're newer medications. There's more efficacy. There's not a single older agent that can provide me with an efficacy of a GLP-1 receptor agonist. You're looking at most of them out there with baseline A1Cs 8.1 to 8.3. You got 1.5% A1C reductions. Some of the SGLT2 inhibitors up to 1.1% A1C reductions. And they're not making our patients gain weight. And they're not causing hypoglycemia, which is safety for our patients. And guess what? When you don't cause hypoglycemia, I don't have to check my glucose as often. So I'm saving on strips. I'm saving on ER visits. I mean, there's a reason that we recommend these newer medications is because they're better and they're safer. And they have now perhaps cardiovascular benefits for our patients. I know they're expensive and bringing new products to market are expensive. But we need to find a way for patients to be able to access this, especially the most vulnerable of our patients, which are elderly Medicare patients for whom we see the most restrictions on medications, for whom cost drives a lot of the decision making, despite the fact that you may be pushing them into medications that are not nearly as safe and certainly don't have the cardiovascular benefit. I think it's important to treat our patients aggressively early with type 2 diabetes. I mean, a lot of studies show if you can get them down and keep them down for a long period of time, even if they lose control later, they still have markedly reduced cardiovascular events and microvascular events. And now that we see cardiovascular outcomes trials, the thought is that that's also true for these agents. The other thing I'd like to go back to is let's go back to the ADOPT trial and let's look at sulfonylureas and the time to failure, 2 years. They are the least durable medication on the market. Forget the weight gain, forget the hypoglycemia. Their durability is not good. Metformin, a little bit better. TZDs, perhaps in the ADOPT trial, the best. I can tell you, I've got patients that I have on metformin and a GLP-1 receptor agonist, and I put them on it 10 years ago. They're still on the same medicines. I haven't touched their diabetes in 10 years. I've dealt with their back pain, their depression, menopausal hormone replacement, everything else that we do in primary care. And I haven't touched their diabetes. And so some of these question marks in addition to cardiovascular outcomes is the durability of the effect of the medication. For example, with GLP-1 receptor agonists, are we stabilizing beta cell mass? Are we preventing apoptosis and loss of beta cell functioning? Are we slowing that progression to ultimate beta cell failure and the need for insulin replacement? I think so. A lot of experts think so. We haven't had as much time in the marketplace in clinical experience with SGLT2 inhibitors, but if you look at some of the clinical trials, they don't tend to regress back to baseline. My patients who've been on SGLT2 inhibitors for 3 years, they're doing great. So a lot of this is, are we using better medications? Can we slow the progression of the disease? Can we preserve not only A1C, but their health longer with the newer medications? I firmly believe we can. We don't have a lot of new classes of medications coming in, but we do have a lot of new sort of core formulations. So now we have 2 basal insulins with GLP-1 receptor agonists that save patients injections. We have some new SGLT2 inhibitors entering the marketplace. There's a lot of investigation, but I don't see anything in the next 2 to 3 or 4 years on the horizon. They're going to be like, oh wow, here comes the new latest, greatest class of medication. I think what we have for type 2 diabetes are fantastic medications. One of our biggest problems with getting the results that you see in the clinical trials in our patients is adherence. They get hypoglycemic, they stop the medication. They gain weight, they stop the medication. They feel better because they've lost weight. They feel better because their A1C is down. They feel better because their diabetes is better controlled. Guess what? I'm going to tend to refill my medication more. So I think right now for type 2 diabetes, we have a surplus of good medications. The key is to teach those who take care of diabetes, particularly the non-experts, the primary care providers, nurse practitioners, PAs, primary care physicians, how to best use these agents, and then making sure that we get access for these medications for our patients. I think it's critically important as we look at the next 10 years of diabetes in the United States that we find a way to slow the progression of this disease, use better medications, and as we've talked about, maybe even prevent heart attack and stroke down the line.